Hello everyone, my name is Madison Marsh, the president and founder of the Whitney Marsh Foundation, and today I'm joined by Dr. Michael Rosenthal for another series in our Pancreatic Cancer Awareness Month.
My name is Michael Rosenthal. I'm a radiologist at Brigham and Women's Hospital and Dana-Farber Cancer Institute. I spend most of my time providing care to people with pancreatic cancer within the Dana-Farber system. I also run an artificial intelligence research lab at Dana-Farber.
So you're a radiologist. What does that mean?
My job as a radiologist is primarily to understand from images a patient's situation in their clinical care. And so that might mean that a patient has a high risk for developing something like pancreatic cancer and is coming to us for screening, or it might mean that the patient already has pancreatic cancer and is having ongoing care. My job is to look at images like CT scans and MRIs, interpret those images, understand the anatomy, understand the pathology that's developing, and help the care team, including oncologists and surgeons and radiation oncologists, provide the best possible care to those people.
Wow. So how did you get involved in pancreatic cancer? What interested you about it, and when did you really get your start?
It's been a long journey. When I was in college, I was a computer scientist and decided that I really loved medicine after volunteering for emergency medical services on our campus at Carnegie Mellon. From there, I went into an MD PhD program where I did medical school and graduate school. I did my graduate school in computer science and worked on image guidance for medical procedures. From there, I had to decide how I could best use this mixture of computer science and medicine together, and radiology was a natural choice for me. So I came to Boston to Brigham and Women's Hospital. I did my residency there and ultimately ended up at Dana-Farber doing cancer imaging. Now that I've been in cancer imaging for a while, I was looking for the most impactful place where I could work. And pancreatic cancer is one of the most challenging cancers to diagnose, to treat, to understand. It's also one of the areas that has the most hope for improvement and the most important need to make progress in a cure. Right? People really need progress in early detection, in better treatments to arrive at a cure in pancreatic cancer. I'd say more so than really any other cancer that's out there.
So then how does your role in medical imaging play a part in pancreatic cancer?
So medical imaging is very important in pancreatic cancer in three different ways. First, in early detection of pancreatic cancer, there are people who have a family history of pancreatic cancer or have a genetic predisposition to cancer. And those predispositions can mean that having a regular screening study makes sense for them. It's worthwhile for them, and it can improve their lives. Right now, those people will undergo annual MRI or endoscopic ultrasound. I'm involved in reading the MRI side of this, and so we're looking at those imaging studies. We're trying to find signs of early pancreatic cancer that we can intervene on. And very high quality studies have shown that when we can find a pancreatic cancer in those individuals using these tests and remove it surgically, they do much better. They have much longer survival, they have better quality of life than if those cancers were to be diagnosed through routine clinical developments. The patient develops pain or jaundice. I also provide care to people who are at the time of a diagnosis of pancreatic cancer. So they've developed symptoms that look like pancreatic cancer. They don't know they have pancreatic cancer yet. They may have a study at an outside hospital that suggests that there's a lesion present in the pancreas. They'll come here to our system. We'll do imaging studies, we'll do biopsies to determine if they have pancreatic cancer, what kind of cancer they have, and what the optimal treatment is. The last thing that I contribute to is people who are on treatment for pancreatic cancer. And they may be receiving chemotherapy, or they may be approaching the time of surgery, and we use imaging to ensure that we're giving them treatment that is effective, that is safe, and that is going to prolong their well-being to the best extent that we can.
So can you talk a little bit more on how imaging is used for the early detection of pancreatic cancer patients, or maybe the role that it continues to play while patients are going through treatment for pancreatic cancer?
Sure. On the early detection side, We primarily use imaging to look for the early signs of a lesion. And so MRI is most commonly used for early detection. It's only effective in people who are at high risk for pancreatic cancer because of a familial risk or a genetic risk. But when we're doing those studies, we're looking for the development of a small mass or changes in structures within the pancreas, like the pancreatic duct is a small tube that runs through the pancreas that can become dilated when there are early signs of disease. These are the subtle changes that we're trying to find early on so that we can target a biopsy, identify that there's a cancer there, and get to surgery, which is ultimately the path to cure currently.
So can you explain a little bit more on what imaging techniques are primarily used in pancreatic cancer, or really just general cancer imaging?
There are 4 different modalities that we use most commonly in imaging for pancreatic cancer, either for screening or for diagnosis. CT, MRI, PET-CT, and endoscopic ultrasound. MRI is the modality that people who are in early detection programs will see most commonly. MRI uses strong magnetic fields and radio waves to take pictures of the inside of the body. It's a very amazing technology. People don't love being inside an MRI machine. If you've ever been in one, it makes loud noises and such, but it has some tremendous advantages. The first is that it provides the ability to distinguish different types of tissue better than really any other imaging modality. It's extremely versatile in this. And it can allow us to image very small structures like the fine details within the pancreas very effectively. It also has the advantage that there's no radiation associated, no ionizing radiation associated with it. CT is the most commonly used modality across all centers for any kind of cancer imaging. CT uses X-rays to take pictures inside the body. It does use some ionizing radiation. It's a very small dose, relatively speaking, and it produces images that are quite sharp, but don't have as many different ways of pulling out details between tissues as MRI. Endoscopic ultrasound is another very important modality that's used in early detection and diagnosis of pancreatic cancer. Endoscopic ultrasound uses a small camera with a little ultrasound probe. Ultrasound makes very high frequency sound waves and bounces them through tissues to take pictures. That camera is placed on a tube, and you have to have an endoscopy, so put the tube down your throat with sedation and put the ultrasound camera next to the pancreas, and they can take very detailed pictures. Endoscopic ultrasound also allows them to do biopsies immediately, and so it can give us a full spectrum from detection to biopsy and diagnosis all in a single procedure. PET-CT is the last modality that we sometimes use in pancreatic cancer. PET-CT uses a molecule. There are several possible molecules, but it uses a molecule that's labeled with a radioactive substance. And that molecule preferentially goes to the site of the tumor. And then we can take pictures of the radioactivity that results in that. It is a little more radiation dose than a CT scan, although it's gotten a lot lower than it used to be. And it gives us really exquisite pictures, but it's not the main modality that we go to first. It's more of a problem-solving tool when we can't answer the questions using all of the other tools available.
So we've seen a lot recently about artificial intelligence. How did you get into artificial intelligence? How does it impact pancreatic cancer or just cancer research in general?
Artificial intelligence is so exciting right now. When I was in graduate school for computer science, artificial intelligence was in its dark ages. And it was before we had efficient tools for training neural networks. Neural networks have been around for many decades, but we didn't have a way of really training complicated ones. We were limited to just very tiny ones. And so at the time, it was a bit of an archaic niche. Around the time that I finished graduate school, there were some amazing developments in the math behind neural networks and in the hardware. Ironically, it was gaming systems that produced the graphical processing units that actually allow us to train these networks efficiently and have become many millions of times more efficient since then. all of a sudden, we can use AI to do things like interpret speech, to translate between languages, to recognize images. These amazing tools are just coming out every day, and it's fantastic. I am very, very excited about the improvements to medicine that are coming down this pike now. In the last 2 years, there have been some amazing developments in pancreatic cancer from artificial intelligence. So we have 3 new biomarkers for early detection of pancreatic cancer, when previously we had basically none. So our group has been working on detection of muscle wasting for quite a few years now. It turns out that people begin to lose muscle very early on in the process of developing pancreatic cancer. Until recently, you had to manually analyze things like CT scans to measure muscle. We developed a fully automated way of doing this, and so we've now been able to process hundreds of thousands of CT scans to do this. This year, we published a paper showing that if you look at people who go on to develop pancreatic cancer up to 5 years before their diagnosis and compare them to people who do not go on to develop pancreatic cancer, there's a progressive loss of muscle that happens that we can measure from these CT scans. And this is very exciting because it's one of the first really clear signals that we have that there's pathology that's detectable before a clinical diagnosis. Now, we still have a lot of work to do to understand how that translates into doing this in a big population, and we're actively engaged in that, but it's a very exciting development that has been entirely enabled through the progress in artificial intelligence. Another very exciting biomarker that's developed from artificial intelligence is something called radiomics. So radiomics is a fancy way of saying that we look at the pattern of the pancreas itself, the pattern of the imaging appearance, and we look for fine details like the texture and the brightness and how it enhances to understand what's going on inside the pancreas itself. So in the last 2 years, there have been a couple of groups that have published really spectacular papers showing that we can look at the whole pancreas, and even if you can't see a lesion there, you can find changes in these radiomic features that distinguish people who go on to develop pancreatic cancer in the next 3 to 36 months from those who don't.
Wow.
So again, another very exciting sign that there's pathology going on before the clinical diagnosis that might be detectable.
Wow.
The last piece of this comes from a totally different end of the spectrum. Our group, working with Chris Sander, formerly at Dana-Farber, now at Harvard, and Søren Brunak in Denmark, helped to develop a system that looks at diagnosis codes in the medical records. So diagnosis codes are used for things like billing and for allocation of care in the US and around the world. They're pretty mundane administrative codes usually, but what we found was that you could look at the series of these over time, and you could actually use them to distinguish people who went on to develop pancreatic cancer from those who didn't. And that there was a signal that extended more than 12 months before the diagnosis. So an unexpected location, it looks like a combination of things like unexpected weight loss, some abdominal pain, new onset diabetes, things that we know are associated with pancreatic cancer, but we were surprised that we could so clearly detect these from basically billing data in the medical record, and that it did better than our best clinical models for pancreatic cancer risk.
Wow.
So all 3 of these are novel biomarkers that have been enabled by artificial intelligence. I don't think it's the end of it, and I'm very excited to see what comes in the next few years.
That is amazing. So how do you actually translate all of these wonderful new artificial intelligence research to actually getting to patients, impacting early detection and patient care?
That's a fantastic question, and this is really our focus at Dana-Farber and the Hale Center. We want to get these changes into patients to improve their outcomes. So we are just about to open a new clinical trial that will be looking at high-risk families, families with pancreatic cancer or people with genetic risk of pancreatic cancer, and doing new tests to screen for pancreatic cancer. Now, those tests will include our standard of care things like MRI and endoscopic ultrasound. They'll also include some new blood tests that we've been working on with our colleagues around the world. And they will also include some evaluation of these new artificial intelligence techniques. Now, we have to be careful about this because we don't know how well this works when we start applying them to very large groups of people. So at first, we're going to be doing these analyses and looking at the results and seeing if there is an actual signal that we might be able to intervene on. If we find that there's a signal there that works in these prospective studies where we're bringing people in and watching them, then we will ask for approval to start to take action based on those results in people. And that would be a landmark change. That would be the time when we start to have real hope that we change people's lives, that we change people's outcomes. Ultimately, we'd love to be able to do this in the whole population and to make a broader difference. That's a couple of years away. We're doing some work to lay the foundation for that. But understanding how we do this in millions of people is a little bit of a different question than how we do it in just those highest risk people that we focus on now.
Wow. Is there anything that you think that our audience should know about pancreatic cancer that you want to leave them with to make them more educated and aware of the disease?
Yes, I think the most important thing is to not ignore symptoms. You know your body best. If you have symptoms that seem like they're different than usual, then talk to your doctor about it, and they can help down this pathway. If you know that you have a family history, you've had a brother, a sister, mom, grandparent who have had pancreatic cancer or have had any cluster of cancers, talk to your doctor about it and ask if you're the right person to go and see a genetic counselor. We do have special programs that can help to identify people who are at risk and that can help to detect cancers and cure cancers early for people who are on these risk groups, but it only works if people come and participate.
Thank you so much for sharing all of your insight and your research today. We hope that this series today was informative for you, and we urge you to go receive care from your physicians if you believe that you are experiencing symptoms or have questions about pancreatic cancer. Thank you for joining us in this fight against pancreatic cancer, and we hope to see you next time.